Hi, I'm Kelly McGuire. I am the Medical Director of the Translational Medicine Program at New York Presbyterian Hospital's Center for Autism in the Developing Brain, where I'm also an Assistant Professor of Psychiatry. And I've been asked to start off by giving a little bit of a background as to what brought me to this field, and that's my mom. She is a nurse for individuals with intellectual disability, and she was very involved in the deinstitutionalization movement. And over the summers as a child, she volunteered at a camp for adults with intellectual disability, and that's where my brother and sister and I spent parts of our summers. So these are my summer friends. And so I went from, as a kid, doing arts and crafts with these individuals to being a camp counselor for them, to by high school, I was on the board of director for the Special Olympics, and by college, I was creating programs to integrate people with intellectual disability from group homes into their community. And then in med school, I went into psychiatry because I felt this was the field that best understood individuals with intellectual disability, and I felt that we were in the best place to provide much needed clinical service and also to best coordinate other medical specialties and other ancillary services that they also need. And I enjoy every day of it. This presentation was put together by a friend and colleague of mine, Katie Strategas, who is the medical director of New York START, and who is also an assistant professor of psychiatry at Columbia. She put these slides together, and I'm going to be talking over them for you today. Neither of us have anything to disclose, and what our objectives for the day are to understand the diagnostic features of intellectual disability and autism spectrum disorder, and to discuss how to assess those disorders. So to start off with, the overall prevalence of intellectual disability is about 1 to 3% in the general U.S. population. It's going to be higher for children versus adults. It's going to be higher for males versus females, higher for the milder severity forms of ID versus the higher severity forms of ID. And the risk factors, the categories are prenatal, perinatal, and postnatal, and each of those contribute equally to the prevalence of intellectual disability. There's going to be another lecture that's going to go more into detail on the genetics, but just as a quick overview, when we think of genetic risk factors, we think of syndromes, which are single gene disorders, and those are things that can be found de novo only in the child, or they can be inherited. And the most common inherited form of intellectual disability is Fragile X. That's resulting from the repeat and the variant of the FMR1 gene on the X chromosome. And then other syndromes that can result in intellectual disability are things like neurocutaneous syndromes. This is like tuberous sclerosis or neurofibromatosis, inborn errors of metabolism, and brain malformations like lissencephaly, the absence of cortical folds, or you can have abnormal layering of the cortex. Chromosomal disorders are also called copy number variants because you either have an extra copy or a missing copy of an entire chromosome or a chromosomal segment. So the major chromosomal disorders are going to be the 3 autosomal trisomies of 13, 18, and 21, with trisomy 21, Down syndrome, being the most common genetic cause of intellectual disability. When we think of prenatal risk factors, these would be environmental risk factors, any sort of toxins during pregnancy, any sort of substances used during pregnancy, malnutrition, mineral deficiencies, maternal illnesses, things like hypothyroidism, or maternal infections like toxoplasmosis, syphilis, herpes, anything along the lines that can have very serious consequences for the fetus, even if the mother only has mild symptoms and even if the mother is treated for that infection. Perinatal risk factors are things during delivery. Asphyxia is going to be the most important risk factor for brain damage that could lead to intellectual disability. And any event that leads to any neonatal hypoxic ischemic encephalopathy, like a placental insufficiency, and events during labor and delivery, like eclampsia or a premature rupture of membranes, can cause intellectual disability. Since intellectual disability can have onset throughout the developmental period, there's also postnatal risk factors that can occur as late as adolescence. Accidents that result in loss of consciousness, like brain trauma or near drowning events, infections like meningitis or encephalitis, poisoning from lead and other substances, environmental deprivation, child abuse, neglect can result in intellectual disability, as well as medical conditions such as brain tumors or intractable epilepsy. Surgical, radiation, or chemotherapy treatments can increase the risk for intellectual disability. So the essential features of intellectual disability are deficits in general mental abilities, that's criterion A, that impact adaptive functioning, that's criterion B. And those need to be across 3 domains of reasoning: conceptual, social, and practical. And so conceptual reasoning, that's our academic reasoning, so that's things like reading, writing, language, math, problem solving, judgment in novel situations. Social reasoning is how aware we are of other people's feelings and thoughts, our social understanding, our interpersonal communication skills. Practical reasoning is self-management across different life settings, so that's things like personal care, transportation, finances, occupational skills. So criterion B is met when at least one domain of adaptive functioning, either conceptual, social, or practical, is sufficiently impaired that ongoing support is needed in order for that person to perform adequately in one or more settings, like school, work, or home. Criterion C is met when the onset is during the developmental period. The age and onset of the characteristic features are really going to depend on the etiology and the severity of ID, and we're going to go over that a little bit later in the presentation, as well as there's an additional presentation on intellectual disability that's going to go over that more as well. In general, children are going to come to clinical attention when there's delays in achieving their developmental milestones, and as the demands in the conceptual, social, and practical reasoning domains increase over time and start to exceed their abilities. The last thing that I want to point out before we move to the next slide is that although intellectual disability is generally lifelong, it's not a static disability. So the level of general mental abilities and adaptive skills, it can change over time, for better or for worse. So for instance, worsening or improving of co-occurring psychiatric conditions or medical conditions like epilepsy or hearing or visual impairments can worsen or improve general mental abilities and adaptive skills, whether or not they're treated. The progression of certain genetic disorders can change an individual's level of functioning. For instance, in Rett syndrome, there can be periods of worsening followed by periods of stabilization. In Sanfilippo syndrome, there can be progressive worsening of intellectual functioning. And early and ongoing interventions can improve adaptive functioning throughout childhood and adulthood. As well, changes in the demands of the environment can worsen or improve adaptive functioning. For instance, as a youth leaves school and goes to the workplace, that could go in either direction. School could have had more demands and they might find a workplace setting that's a better fit for them and they're functioning better, or it could be the opposite. Perhaps the demands of the workplace or after school setting is more difficult and they're struggling more in that place. So in some cases, these changes can result in enough of a significant improvement in intellectual functioning that the diagnosis of intellectual disability is no longer appropriate. This is partly why when we're assessing infants and young children, we really delay the diagnosis of intellectual disability until we've made sure that appropriate interventions have been provided for those children. When you read the DSM, you're going to see that you need to assess whether or not approved adaptive skills are the result of stable, generalized skill acquisition, in which case the diagnosis of intellectual disability is no longer appropriate, or if the improvement that you see is contingent upon supports and ongoing interventions. And in that case, the diagnosis of intellectual disability would still be appropriate. Okay, so this slide we're just going to look at really quickly, and what I want you to really pay attention to here is the adjusted developmental age. because this is showing what the average adjusted developmental level is for each severity of intellectual disability. And this is going to be really important to remember because it's going to be the adjusted developmental age, not the chronological age, that we're going to use to base our developmental expectations on, to inform how we communicate with that individual, and how we really begin to conceptualize the level of support that individual might need. I personally find it helpful to remind myself of what the Piaget stage of cognitive development is for each of these approximated ages, approximated developmental levels, and as we go along, I'll talk about that a little bit more. So this is the prevalence. The majority of individuals with intellectual disability, 85% of them are going to have mild intellectual disability, whereas 10% of them are going to have moderate, and 5% of them are going to be the severe and profound, both those two classes. This slide shows us the bell curve of intelligence quotients, IQ, that was previously used to define the severity of ID. Previously, on a test that would have a population mean of 100, intellectual disability was defined as an IQ score of 2 or more, 15-point standard deviations below the mean. So that was 70 was about mild ID, 55 moderate, 40 severe, 25 profound. But IQ scores are not used to define the severity of intellectual disability in the DSM-5. Just imagine a big red X over this slide. IQ scores can be used to assist in the clinical determination of whether criterion A, deficits in general mental abilities, are met, but they're not required. IQ scores are less valid in the lower end of the IQ range, and as you'll see as you're reading your DSM-5, it states that IQ scores are approximations of conceptual functioning, but may be insufficient to assess reasoning in real-life situations and mastery of practical skills. So for example, if you're thinking of an individual with an IQ score of about 70, that person may have such severe impairment in the conceptual, social, and practical adaptive functioning domains that their actual functioning in everyday life may be comparable to that of somebody with a much lower IQ score. So because of this, the DSM-5 bases the level of severity of impairment on adaptive functioning across the conceptual, social, and practical domains, because it's the adaptive functioning in these domains and not an IQ score that's going to determine how much support a person needs in life. And so the severity of ID is now going to be determined by the DSM-5 severity table, and that's going to be on pages 34 to 36 of your DSM. The goal of all of this is that the DSM-5 revision really wanted to emphasize that the psychiatrist has a role in assessing intellectual deficits, diagnosing intellectual disability, and specifying the severity using the severity table. You can use standardized scales in measuring adaptive functionings to assist you in your assessment, but know that these tests do not capture all functional domains, and that even if you do use these tests to assist in your diagnosis, that you're also going to need to use your own clinical judgment and use the DSM-5 severity table. Okay, so there is, as I said, a subsequent lecture that's going to go into more detail over this. This is going to be a very general overview of what individuals at different severity levels of intellectual disability may present like. So let's remind ourselves that on average, an individual with mild intellectual disability is functioning at the developmental level of someone that's about 9 to 12 years old. And so this, in terms of Piaget's stages of cognitive development, this is the concrete operation stage. And that's easy to remember because when you're going through and looking at your severity table, they're going to use the word concrete a lot in the descriptors of how this person is functioning. So concrete operation stage is when people think very concretely. It could be logically, but it's concretely, and they need to use aids, and they may be capable of objective or rational thinking. So in the conceptual domain, individuals with mild intellectual disability, if you think of a 9 to 12-year-old, they're going to be able to achieve about up to a 6th grade education level. And because of this, the intellectual disability might not be recognized until their school age, because it might not be until then that they start to have difficulty academically. In preschool, before that, there might not be any perceptible differences. What you may see is it may have a concrete approach to problems and solutions in comparison to their peers. In the social domain, when we think of their language, their communication, conversation, and language may also be more concrete or immature. They may be more immature in their social interactions, so insofar as perceiving their peers' social cues or understanding risk in a social situation, they may have more immature social judgment. And so this puts them at a higher risk for being manipulated by others. In the practical domain, they may have some skills for self-support, but they might need assistance when they're under stress. Okay, next slide. Moderate intellectual disability. So on average, an individual with moderate intellectual disability, now we're thinking of someone that's functioning at the developmental level of a 6 to 9-year-old. So be thinking of how the 6 to 9-year-old operates in their world. This is the Piaget stage of late pre-operational stage. And so this is a stage of decentralization and symbolic thinking. Conceptually, these individuals may achieve up to a second grade education level. So slowly, over the school years, they'll be acquiring reading, writing, math, understanding of time and money. But all through their development, their conceptual skills are likely to lag behind their peers. And so this is typically detected as early as preschool years because some of their skills are developing more slowly than their peers. In the social domain, their spoken language just tends to be less complex of that of their peers. But please remember, for all of these individuals, that they are capable of having meaningful relationships with their families and friends, and sometimes have romantic relationships in adulthood, even though they may have some difficulty with social judgment or not perceive or interpret social cues as accurately. In the practical domain, they might need an extended period of time to become more independent in personal care needs, but it is something that they could achieve, but they may need support to manage things like job complexities, scheduling, transportation, health benefits, things like that. The next two we've kind of clumped together, but I'm going to talk about them separately. So for an individual with severe intellectual disability, this is somebody that's functioning on the level of a 3 to a 6-year-old. And so now we're in the early pre-operational stage. And so this is a stage where we have egocentric thinking, we have phenomenalistic causality, we have magical thinking. We're still developing our theory of mind. So in the conceptual domain, imagine a 3 to 6-year-old. They may have very little understanding of written language or concepts involving quantity, time, and money. When we think of them socially, their spoken language may be just like single words or phrases. And in the practical domain, they may require support for their activities of daily living, meals, dressing, bathing, so on and so forth. For an individual with profound intellectual disability, now we're looking at someone that's functioning at about the adjusted developmental level of about less than a 3-year-old. So this is the sensory motor stage. This would be, in Piaget's terms, somebody that was still developing object permanence. And so in the conceptual domain, their skills involve more the physical world. They may be able to use objects for self-care and recreation, and they may be able to acquire skills that are more along the lines of matching and sorting based on physical characteristics. In the social domain, they may communicate more through nonverbal communication, like gestures and emotional cues, and they may understand some simple instructions and gestures. In the practical domain, they're dependent on others for all aspects of their daily physical care, health, and safety. Another way, I showed you how I kind of conceptualize adjusted developmental level. This is another way that can be done. This is a way that Dr. Strategas uses more commonly. And so this is just taking the chronicle age, multiplying it by the IQ score, and dividing it by 100 is another means to kind of come up with the adjusted developmental age. Okay. So now we're moving on to autism spectrum disorders. So the most recent prevalence for autism spectrum disorder is 1 in 59. It's about 5 times more common in males than females, but when females have autism, they tend to have more severe intellectual disability. And about half of the individuals with autism have average intellectual disabilities, and about half of them have an intellectual impairment. We have identified some risk factors for ASD that appear to include things like advanced maternal or paternal age, closer spacing of pregnancies, extremely premature births, about less than 26 weeks of gestational age. There's a higher reoccurrence rate for autism in siblings with autism, and even higher risk for autism in identical twins, which really provides strong support for the importance of genetic factors. We have emerging evidence for risk factors that suggest the possibility of inadequate folate prenatally or in the first few weeks of pregnancy, an immune response to infections during pregnancy. There was a study that reported that valproate during pregnancy was associated with an increased risk of having a child with autism, and also environmental contributors such as pesticides, exposure to pesticides during pregnancy. Vaccines do not cause autism. There's a very good policy statement on this that you can find on ACAP's website if it's something that you would like to print out and hand out to your families or read more about yourself. The DSM-5 criteria for autism spectrum disorder is characterized by persistent deficits in social communication and social interaction across multiple contexts, as manifested by deficits in all of the following: social emotional reciprocity, nonverbal communicative behaviors used for social interaction, and developing, maintaining, and understanding relationships. And this criteria must be met based on historical information, and the current presentation needs to be causing impairment. So some examples of social emotional reciprocity deficits would be like an abnormal social approach, failure of like a back and forth conversation, reduced sharing of interests or emotions, a failure to initiate or respond to social interactions. An example of deficits in nonverbal communicative behaviors would be abnormal eye contact or use of body language, difficulty understanding the use of gestures, a lack of facial expressions, poorly integrated verbal and nonverbal means of communication. The deficits in developing and maintaining and understanding relationships are things like difficulty adjusting your behavior to suit different contexts, or difficulty sharing imaginative play or making friends, or an absence of interest in peers. The next domain, in addition to the social communication deficits, the diagnosis of autism spectrum disorder requires the presence of restricted and repetitive behaviors, patterns of behavior, interests or activities, and this has to be manifested by 2 of the following. So what we're looking for is stereotyped or repetitive motor movements or use of objects or speech, insistence on sameness, some inflexible adherence to routines, ritualized patterns of verbal or nonverbal behavior, highly restricted, fixated interests that are abnormal in intensity and focus, and hyper or hypo reactivity to sensory input or unusual interest in the aspects of the environment. So just quickly, some examples of what that would be. So stereotyped or repetitive motor movements, these are the things, the motor stereotypies like hand flapping or finger flipping, the lining up of toys or flipping the objects, echolalia. Insistence on sameness would be things like extreme distress at small changes, difficulty with making transitions, very rigid thinking patterns, highly restricted and fixated interests. Examples of that would be, for instance, somebody that had a very strong attachment with an unusual object or a non-functional aspect of an object, or a very circumscribed or perseverative interest, for instance, in a specific model of a train or daily schedules. And then the hypo or hyporeactivity would be, for instance, oversensitivity to environmental changes, adverse responses to like textures and sounds. Okay. Also, like visual fascinations with light and movement, excessive smelling and touching of things. Okay, so really quickly, a slide on history. So autism was first described in 1943 by Leo Kanner, who reported on 11 children with apparent congenital abilities to relate to other people, but who were very sensitive to change in their environment. He emphasized that they had a lack of interest in people, and that this was in stark contrast to the profound social interests of normal infants. And he observed that when they developed language at all, it was marked by a lot of echolalia, pronoun reversal, and concreteness, and that these children also exhibited unusual, repetitive, and apparently purposeless activities, stereotypies. Autism originally was believed to be a form of childhood psychosis, but by the 1970s, various lines of evidence made it more clear that autism was distinctive. And so by 1980, it was officially recognized in the DSM-3. And now in the DSM-5, in addition to the diagnosis of autism, we have more things that we want to be specified. We want individuals to specify whether or not there's intellectual disability, whether or not there's a language impairment, if it's associated with a known medical or genetic syndrome or environmental factor, for instance, like Rett syndrome or Fragile X or Down syndrome. We also want to know if it's associated with another DSM-5 psychiatric disorder, and we want to know whether or not it's associated with catatonia. We also want to know the severity. So we need to list the current severity for both the social communication and the restricted and repetitive behavior domain. And we're listing it as a level 1, 2, or 3, with 1 is requiring support, 2 is requiring substantial support, and 3 is requiring very substantial support. So for a level 1, requiring support in a social communication domain would be like somebody that has difficulty initiating social interactions, and that there would be maybe clear examples of just unsuccessful or atypical responses to others. Whereas a level 1 requiring support in the restricted and repetitive behavior domain would be like inflexibility with your restricted and repetitive behaviors that interferes with functioning in like maybe 1 or 2 contexts. But when we start to get up to a level 2, requiring substantial support in a social communication domain, you start to have limited initiation of your social interactions, and you have reduced or abnormal responses to others. With restricted and repetitive behaviors, now they're frequent enough to be noticeable to the casual observer, and it's interfering with functioning in a variety of contexts. When we get up to level 3, requiring very substantial support in the social communication domain, now we have very limited initiation of social interactions, and we have very minimal responses to others. When it comes to the restricted and repetitive behaviors, now it is markedly interfering with our functioning in all spheres. And so when you list someone with autism spectrum disorder, you're going to say, for instance, communication level 1, restricted and repetitive behavior level 2, so on and so forth. The diagnosis needs to have more verbiage to really specify and capture this individual. Some people have a lot of questions as to the meaning of certain terms that we use in regards to communication and intelligence, so we're just going to go over those really quickly. Echolalia is repeating back what the other person has said, either immediately or at a later time. They may or may not reverse pronouns. In some ways, this relates to stereotype phrases or scripting in which the person repetitively repeats memorized lines that they've previously heard. Concreteness is when we have very literal interpretations of words. Poor pragmatic language is what our social use of language is, and so that's difficulty with just smoothly changing topics, difficulty with our back and forth conversation, changing your interaction style based on a different setting, and maybe saying socially inappropriate things. In regards to intelligence, the results of standardized tests of intelligence tend to show a lot of scatter for individuals with autism and intellectual disability. And so there might be areas of strengths and areas of weaknesses. And so the term splinter skills refers to just unusual kind of islands of ability. And then another common finding is that some individuals will have a split in their nonverbal versus verbal reasoning, with sometimes their nonverbal reasoning can be much stronger than their verbal reasoning. And then deficits in abstract thinking just refer to difficulty, like the thinking concretely, difficulty taking perspective. Going back to our DSM-5 criteria, the symptoms need to be present in early development and cause impairment. So the first symptoms of autism are typically recognized during the second year of life, sometime between 12 to 24 months. And they frequently involve delayed language development. It's often accompanied by a lack of social interest or unusual social interaction. You may pull somebody by the hand without looking at them to get something you want. You might have an odd play pattern. You might carry toys around but not really play with them. You might have unusual communication patterns, knowing the alphabet but not being able to respond to your own name. But some features, like the stereotyped movements, the odd and repetitive behaviors, those might develop later. And some symptoms might be seen earlier if the developmental delays are more severe, whereas other symptoms might be seen later if your symptoms are more mild. Just know that the symptoms are not age-specific and that they might change with development, and some of them may or may not fully manifest until social demands exceed that individual's abilities. So it's for these reasons that the DSM-5 criteria are independent of age and intellect. Some individuals can come for their first diagnosis of ASD in adulthood. Intervention, compensation, and current supports can mask people's difficulties in some contexts, but symptoms will still remain sufficient enough to cause an impairment in social, occupational, or other areas of functioning. And so when your clinical observation suggests the diagnosis of the criteria is met for a diagnosis of autism, make sure that there's also good evidence that we also had difficulty with social and communication skills in childhood. Know that although 45% of individuals with autism have both autism and intellectual disability, make sure that the social communication difficulties that you're seeing are not better explained by intellectual disability or a social communication disorder. Make sure that the restricted and repetitive behavior criteria are also met before you diagnose someone with autism. Okay, now we're going to go into the assessment of developmental disabilities. So when you are making an assessment, you're going to do your standard diagnostic psychiatric assessment. So you interview the child and the family, you review past records, you collect historical information, and you're very careful of the DSM-5 diagnostic criteria in areas that are going to be relevant to differential diagnosis. And when you're doing this, you need to consider behaviors that are typical of the child's adjusted developmental age, not their chronological age. So when you're looking at the child, you're going to be looking at the child's adjusted developmental level, and you're going to maybe have to require an interview based on that. You might have to simplify your questions. You might have to allow some extra time for them to process the question, avoid leading questions, check in to make sure they're understanding you and not just giving you a rote yes or repeating what you said. And what you're going to be doing is you're going to be observing their behaviors, their functional abilities in play, their emotional expression, their social interaction with you and the family, how they're communicating. And then you're going to do a parent interview and history. You're going to want to get a prenatal and perinatal history, a developmental history. You want to get information on how changes have occurred over the course of development and in response to intervention. You want to review past and current educational and behavioral interventions. You want to get a really good baseline of their strengths and weaknesses across settings. You want to know their cognitive and executive executive functioning, how they express their emotions, their receptive and expressive language skills, their typical behaviors, and then you want to know about any changes from this baseline and get a good understanding of that. You also want to do your psychiatric review of systems to be considering any comorbid psychiatric diagnoses, and you want to get a family history. We recommend a 3-generational family history, thinking of not only psychiatric disorders, but medical problems, learning disorders, any ASD or ID, and you want to make sure you assess for relevant psychosocial issues. And then you also want to make sure you're getting collateral from school, other providers from any prior records, and you're going to be looking for any discrepancies in the level of support they have in these different settings and maybe how they appear in these different settings, and to evaluate if the underlying impairment would change if some of these accommodations were removed. Next, we want to do an etiologic evaluation to determine the etiology of ID or ASD. And this is something that a child and adolescent psychiatrist can perform, but you can also refer to a clinical geneticist, a developmental behavioral pediatrician, a pediatric neurologist, somebody that's going to be comfortable with doing a detailed history, physical, neurological examination. Those are going to be the most critical components of an etiologic evaluation, and then also genetic testing is going to be the next most helpful component. So the physical exam, you're looking, or they are looking for physical features, growth, minor abnormalities, make sure that all children with autism and intellectual disability are screened for vision and hearing impairments, because they're at a greater risk for these, and speech and language delay can actually be the result of hearing loss, and a correction of that could improve their developmental outcome. And then for children with autism, it's recommended that they have a Woods lamp examination for signs of tuberous sclerosis. Then genetic testing I'm going to go through quickly because we also have another lecture that goes over genetic testing. But if family history, patient history, or physical findings suggest a specific etiology like Down syndrome, hypothyroidism, or lead exposure, you would confirm that with specific testing. And if there was an abnormal or indeterminate result, that would warrant, further genetic evaluation or counseling. If there isn't an etiology that's strongly suspected from the history in the exam, then there's a stepwise approach to additional testing that's going to be outlined in the upcoming intellectual disability practice parameter and is also going to be discussed more in the genetics lecture. But after that additional testing, it's a chromosomal microarray is the current genetic test with the highest yield in children with unexplained intellectual disability. And so it's recommended for all individuals of intellectual disability of undetermined etiology, and it's also the standard of care for the initial evaluation of children with autism. And then there's other tests that could be ordered if needed, like an MRI based on historical findings or physical findings, or abnormal neurologic findings, an EEG if there were seizures, if we're suspected. And then other referrals you want to think of when you're doing your assessments. You want to think of a communication assessment to look at receptive and expressive vocabulary and how they're using language to see if they need any communication supports. This is typically done with a speech and language pathologist, occupational and physical therapy evaluations to evaluate for motor impairments and hyper or hyposensitivity and any challenges with their activities of daily living, behavioral assessments to look at the functions of behavior and understand what may be maintaining these behaviors. This is typically done with a psychologist, a behavior analyst, or someone with training in applied behavior analysis. People might need a sleep study, and then we've talked about neuropsychological testing that can be done that can help better understand the strengths and weaknesses for academic skills and can help in treatment planning and inform the level of support they might need. There are also additional assessments. Various instruments for the assessment of autism have been developed. These are all assessments that can aid in the diagnosis of autism, but are not required for a psychiatrist to make a diagnosis of autism, although it may be required by certain schools or other systems in order for the provision of services. But as a practical matter, all of these instruments are going to vary in their usefulness for clinical practices, and some of them are going to require specific training. And just know that the use of these instruments can inform, but it's not going to replace your clinical judgment. A tool that I really like that you can get for free online is the Autism mini mental status exam developed by Dr. Grodberg, and I find this very helpful when I'm writing up my mini mental, and the standard verbiage that you have in your training doesn't always necessarily capture our kiddos. So I won't go into this in detail, but it's something you can get and have on you, and I think it's very helpful. Common presenting symptoms in individuals with autism and intellectual disability. These are a lot of the things that are commonly going to bring them into your office. Hyperactivity, irritability, tantrums, aggression, self-injury. We also have a presentation that goes into the assessment of these and, separating out a differential diagnosis and a treatment approach based on these. And just know that regardless of the severity of intellectual disability or autism, that really a mismatch in someone's ability and the expectations of them can really lead to frustration, and it can impact someone's self-esteem and lead to behavioral disturbances, which then often leads to the referral to us that then can sometimes lead to the detection of the autism or the intellectual disability. Individuals with autism and intellectual disability have a higher likelihood of having co-occurring psychiatric conditions. These percentages are listed for autism. Psychiatric disorders also occur at least 3 times more frequently in individuals with intellectual disability, and in particular, oppositional defiant disorder, ADHD, anxiety disorders, and autism spectrum disorders. So just keep in mind when you're evaluating these kiddos to be thinking of any potential co-occurring psychiatric disorders. And this is also a separate presentation that can be gone into more about how to assess for these and what your treatment options are. Also, individuals with intellectual disability and autism are just like every other child going to have common problems. And so if they have a difficulty communicating their pain, you may be seeing behavioral problems that are due to an ear infection or an injury or a headache. And so you need to assess for common medical problems and keep them in mind. Our kiddos on the autism spectrum tend to have an increased frequency of GI problems. Individuals with autism and intellectual disability have a higher likelihood of having epilepsy. And if one of your kiddos has a genetic disorder, refer to the literature to remind yourself of any specific medical problems that might be more likely in that individual. So really quickly, in the last few minutes, we have just talking about the family, social, and cultural system. So one of the things that we need to be thinking of is putting the person first, treating the entire family. Children with disabilities, this is a family affair. It affects the entire family. We need to help the family navigate resources. We need to be very culturally competent in the family's kind of understanding of what's going on with their child, and we need to really understand the parent's perspective of what's going on with their child. And we need to parents often are better able to anticipate and plan ahead of the professionals when it comes to transitions, but we need to be thinking of those as well and helping them with it. Know that the caregivers are often very overwhelmed and exhausted. They're often very socially isolated. And they have a daily struggle having to advocate for what their children need. And we also need to be sensitive to the fact that boundaries that may seem odd for the chronological age of their child might not be so odd if we think of the adjusted developmental age of their child. It's good to have parents have a place to sort of let out their thoughts and their feelings. We really want to make sure that they are part of the decision-making process and that we're incorporating the information on their child. They are going to be the ones that are providing very accurate and helpful information that's going to be informing our decisions. And we also need to be taking care of the family. We need to help advocate for them to be getting respite, their supports. We need to be helping them find the financial aid and entitlements when they need it, or working with a social worker or somebody else in your practice that can help the families navigate these things. And, continuing to stress that, the parents are the ones that are going to know their kids. They're the ones that are going to be most familiar with how their child functions and when something is unusual. Somebody may look at a child with autism or intellectual disability and see things as unusual that are actually more of their baseline and not interrupting with the child's functioning or a treatment focus, whereas the parents may have something very specific that they see as different and is. So listen to the family and respect their perspective and their philosophy. Continuing, the family is a very valuable source of information. Make sure that you're always giving them very up-to-date information about treatment, that you're helping them navigate social services, you're involving them in the decision-making process, that you're helping them advocate for their child across their lifespan. And make sure that you're providing culturally competent care, and that different groups of people are going to have different understandings and different perspectives as to what a disability is. This is a case example that we won't be going over now, but it would be helpful for you to read to see an example of family care and really have the take-home point of that medication alone isn't the sole crux of what we do, and it alone is not going to address all of the various issues and needs of our patients, and that we need to really be providing intensive psychosocial interventions and coordination. So the goals of all of our care, we're here to maximize an individual's functional independence and their quality of life through development and learning, improvement in social skills and communication, reductions in their disability and comorbidity, promotion of independence, provision of support to the families. And then here's our summary slide. ASD and ID are common, and it's really essential that child and adolescent psychiatrists are comfortable working with this population and providing care to them and doing all we can to contribute to their well-being. And that when you evaluate an individual with intellectual disability or autism, that you're assessing for all the possible co-occurring psychiatric disorders and medical problems, and that you should pay a lot of attention and sensitivity to the family's experience. And here are some references from which our information was drawn from. Thank you.
My name is Dr. Kathleen Koth. I'm just going to ask some application questions here at the end to help further our understanding of this wonderful information. What is the most compelling basis for determining the level of severity for a patient's intellectual disability?
The DSM-5 severity table.
Okay, and that's very easily found in the DSM?
Yes.
Okay, good. What's the most common form of intellectual disability that a clinician may encounter?
Mild intellectual disability. It's 85% of the population of individuals with intellectual disability.
Okay, so it's most of what a child and adolescent psychiatrist in the community may see.
Yep.
Okay. When do parents tend to become concerned about delays in the child's development?
Some general benchmarks are a child who is not standing by about 15 months, not walking or using words by about 20 months, and not using phrases by about 30 months. There's also subtle things that the parents will notice, maybe not using eye contact, not pointing, things like that.
Okay. Is it possible that a school-age child might come into clinic and nobody have noticed these things beforehand?
Yes, depending on the severity of the intellectual disability. The demands of the situation may not have exceeded their abilities yet. So it might be that a child's difficulties with intellectual disability might not be picked up until later, when it starts to get to that threshold of the demands are exceeding their ability.
Okay. So it could even be in elementary school or later. Okay. Which instruments are universally recognized as the most valid instruments for the diagnosis of autism?
So instruments that can aid in the diagnosis of autism are things like the Autism Diagnostic Observation Schedule and the ADI. It's a diagnostic interview. The ADOS is something that you're going to require training for, but these are both measures that are seen as gold standards in the field, and the information that they provide can really help aid a psychiatrist in their diagnosis, but you need to use your clinical judgment because there can be false positives. There can be things that could score as autism on an ADOS or an ADI or other measures that we would be able to use our clinical judgment, for instance, that the lack of eye contact was maybe due to anxiety or ADHD or something like that.
Okay. Can a child psychiatrist in the community make the diagnosis of autism spectrum disorder?
Yes.
Do they need to have to do an ADOS themselves?
Nope, no ADOS is needed, just your DSM-5.
Wonderful. Thank you so much for that information.
Thank you.